So now let us continue with the middle ear cleft. So still now we had discussed regarding the external ear completely. So I am just discussing mainly the MCQ points. So let's see. So here in case of anatomy of middle ear cleft, there are three parts. As we had seen in the external ear, here also three parts, that is tympanic cavity, Eustachian tube and mastoid air cell system. So let me show you how it is. Few anatomical diagrams. So now let us see the different parts of middle ear. So this is the middle ear cleft, and here comes the ET tube, that is none other than Eustachian tube, and here comes the tympanic cavity. Completely this part is the tympanic cavity. So here in case of tympanic cavity, we have three different parts. First one, mesotympanum, then epitympanum, and hypotympanum. So there are three different parts inside the tympanic cavity. Let me show you where it exists. So here epitympanum, that is in the upper part, and then comes the mesotympanum in the middle part and hypotympanum in the lower part of the tympanic cavity. So there is nothing more to study in detail. So only one thing, this mesotympanum is the widest part of the tympanic cavity, and then comes the third part, that is the mastoid air cell system. Okay, so these are all the three different parts of the middle ear. First one is Eustachian tube, then comes the tympanic cavity. So in case of tympanic cavity, we have epitympanum, mesotympanum and hypotympanum, and this mesotympanum is the widest part, and next comes the mastoid air cell system. Okay, so this is the mastoid air cell system. So this is the idea regarding the middle ear cavity. So let's move forward. So now regarding the contents of tympanic cavity, there are different things regarding the walls of tympanic cavity, but that is not important in MCQ point of view. So let's see. So since first year we all know that there are three bones inside the tympanic cavity, and those were malleus, incus and stapes. So here comes the malleus, and then comes our incus, and at last comes our stapes. And this is the foot plate of stapes, which gets inserted into the inner ear, it will be getting connected to the inner ear. Okay. So here you people already had seen the discussion regarding the tympanic membrane, where we had seen the handle of malleolus attaching here, and I think you can now imagine somewhat how this inner ear and external ear and middle ear got connected. So here comes the tympanic membrane, and the handle of malleus will be here, and here comes the umbo, and anteroinferior part we will have the cone of light. So same way it is extending inside malleus, incus and stapes. So here in case of malleus and incus, they were formed from the first arch. Okay. And this malleus, this malleus and the incus were started from the first arch, and this stapes originated from the second arch, and here the largest ossicle is incus, and here the shortest one is stapes. Okay, so it is triple S, and here the foot plate of stapes is held to the oval window by the annular ligament. So this foot plate is connected to the oval window. So this is the thing you should know regarding this different ear ossicles. So in case of ear ossicle, the malleus is also developed from the first arch, and incus from the first arch, and this incus is the largest one, and stapes, that is second arch and shortest bone, and this foot plate is held in the oval window. Okay. So here regarding the joints, which we will be seeing in the next slide. Before that, for idea I am just writing here this that joint between the malleus and incus, that is incudo-malleolar joint, is of saddle variety. Saddle joint. And this one incus and stapes, this one is of ball and socket variety. I am just mentioning here so that there is no need to repeat the diagram. You will understand what is going on here. So you can easily remember incudo-malleolar joint is of saddle variety by remembering that I am sad. Okay. So and the next one, that is stapes and incus, is having the ball and socket variety. So let's move forward. So here, as I had mentioned, incudo-malleolar joint, that is I am sad wala, and incudo-stapedial joint, that is ball and socket variety. And here there are two muscles. One is tensor tympani, which arises from the first arch, and it is supplied by the mandibular nerve. And here stapedius is a muscle which develops from the second arch, and it is supplied by facial nerve. Okay, so try to remember this nerves and where the muscles originated from. And now we are moving to the mastoid antrum, which is the third part of middle ear cleft. So this mastoid antrum is the air sinuses in the petrous part of temporal bone. It is located here, and it develops both from the squamous and petrous bone. And here this mastoid antrum is completely filled of air cells. So here it is mentioned that 80% of mastoid antrum were pneumatized, that is air cells will be present, and 20% of sclerotic, and the remaining will be of few will be of mixed variety. And here this air cell pneumatization begins in the first year and is complete by 4 to 6 years of age. So while the baby is born, there is no air cells in the mastoid antrum, and it gets completed only by 4 to 6 years of age. So here the location is more important and pneumatization is more important. Okay. So pneumatization begins in first year and is complete by 4 to 6 years of age regarding this mastoid antrum. And now comes the Eustachian tube. So try to remember the image which we discussed before. So here this Eustachian tube connects the tympanic cavity with the nasopharynx. So here what happens, what is the action or help of the Eustachian tube? It helps to equalize the pressure on both sides of the tympanic membrane. Like we know, inner and outer surface, outer surface is of external ear and inner surface is of middle ear cavity. So here both the pressures will be maintained by this Eustachian tube, and this Eustachian tube is of 36 millimeter, and here some special type of fat is there, that is Osman pad of fat. So here it helps to close the tube, like it is connected directly to the nasopharynx, but the whatever the secretions which are present in the nasopharynx should not come inside the ear. So in order to prevent it, this tube is closed by the Osman pad of fat. Okay, there will not be any reflex secretions of nasopharyngeal into the middle ear. So that is prevented by this Osman's pad of fat, which we can think as a natural barrier. And then comes the muscle, and here it is tensor palatii, that is branch of mandibular nerve. It helps in the opening of the tube whenever it contracts. And levator palatii, and it is supplied by the 10th cranial nerve. And here there is a lymphoid tissue of Eustachian tube, which is also called as tubal tonsil or Gerlach tonsil. Try to remember this, also known as, okay. Every time they used to ask MCQ out of it. So like few direct questions we may expect in this type of question. So I am just repeating. So this Eustachian tube is one of the part of the middle ear, and it connects the tympanic cavity with the nasopharynx, and it helps in the equalizing the pressure of the tympanic membrane. And Eustachian tube is of 36 millimeter, and Osman pad of fat helps in the prevention of reflex of nasopharyngeal secretion into the middle ear. And muscles, that is tensor palatii and levator palatii. Tensor palatii, it is a branch of mandibular nerve, and levator palatii, it is a 10th cranial nerve. And here there is a few lymphoid tissue around this Eustachian tube, which is also called as tubal tonsil, and it is also called as Gerlach tonsil, and it is actually called as tubal tonsil. So this is all regarding the Eustachian tube. Now we are moving towards the anatomy of inner ear. Anatomy of inner ear is little bit complex, because we have one outer layer also and we have one inner layer also, and between the outer and inner layer also we have different anatomical structures, and inside the inner part also we have different anatomical structures. So let us try to understand with the 2D images, and if you have doubt, kindly check any animated image in YouTube or any website. That will be more helpful for you to understand. So here in case of anatomy of inner ear, it consists of both the bony labyrinth and membranous labyrinth. This I was saying, the outer layer is bony labyrinth, and the inner you can imagine like this, that this is the bony area, this is the membranous labyrinth, and outside it is the bony labyrinth. You can think that this bony labyrinth is preventing this membranous labyrinth. So inner ear, outside is bony labyrinth, and inside is membranous labyrinth. And here its important function is hearing and equilibrium. So now let us start with the bony labyrinth. I am not going in detail, so if you have any doubt regarding understanding its anatomy, it's better to check out the animated video. And so in case of bony labyrinth, we have three parts. One is bony cochlea, then comes the vestibule and the semicircular canal. I'll show you how it looks like. So this is just for idea for understanding the bony labyrinth. So here this is the cochlea and this is the vestibule, and here comes the semicircular canals. There are three semicircular canals. So in the bony labyrinth, it is filled with perilymph, which is rich in sodium. Okay, so try to remember it is rich in sodium. So this is the complete bony labyrinth. So as I had told, it is bony cochlea, vestibule and semicircular canals. So next, here comes the semicircular canal. So we are going to discuss regarding it. So before that, I would like to draw the image again. I am just drawing only the semicircular canal for your understanding. Imagine that these semicircular canals are getting opened inside the vestibule. So just imagine that the semicircular canals are three in number. One is superior, posterior and lateral. So this one is the superior one, and then comes the posterior one, and this is the lateral one. So this is just a 2D image. Don't get confused with this. And this ampulla is nothing but the dilated end. So here there are three ampullas, 1, 2, 3, which you can see that there is a dilation of semicircular canal which opens into the vestibule, and then comes the crus commune formed by the non-ampulated ends. You can see here there is no dilatation in this area, so this is called as crus commune. Okay, and then the solid angle is none other than the area of bony labyrinth that lies between the semicircular canal. So I think you might have understood now. Anatomy of inner ear, semicircular canal mainly we are dealing with, which is a part of bony labyrinth. And here there are three different semicircular canal. One is superior, then posterior and lateral. So ampulla is none other than the dilated part. So here you can see three ampullas. And the non-dilated part is also called as crus commune, and the solid angle is none other than the area of bony labyrinth that lies between the semicircular canals. Okay, so we can move forward. And now comes the vestibule. I think try to imagine the diagram which we had drawn previously. So this is the central portion of the bony labyrinth, and lateral wall lies the oval window. This might be confusing, so just try to remember where the vestibule exists. Then comes the membranous labyrinth, which is like I had told you that if it is a bony labyrinth, just imagine that this is the bony labyrinth, and if we are opening the bony labyrinth like this, here we may see the membranous labyrinth. This is just for understanding. Okay, so here tubes within the bony labyrinth, that is membranous labyrinth, which is filled with the endolymph. So in case of bony labyrinth, it is filled with the perilymph or sodium, which is rich in sodium, and inside it is an endolymph which is rich in potassium. And here it includes cochlear duct, article, saccule and semicircular duct. So inside the semicircular canal there are semicircular ducts. Inside the bony cochlea we can see the cochlear duct, and inside the vestibule we can see the article and saccule, which mainly helps in the equilibrium. Okay. So now regarding the blood supply. Arterial supply is by the anterior inferior cerebellar artery, and venous drainage by the inferior petrosal and lateral venous sinus. So now regarding the inner ear fluids, which we had already discussed. So two types of fluid we had discussed. One is endolymph and another one is perilymph. Perilymph, which is present in the bony labyrinth, that is similar to the extracellular fluid, and it is rich in sodium. So as I had told, it mainly fills the space between the bony labyrinth and membranous labyrinth, and it communicates with the CSF through the aqueduct of cochlea. There is an opening, so it easily communicates with the CSF. And here it fills the entire membranous labyrinth as already told, and it is also resembles the intracellular fluid, which is rich in potassium. Potassium always lies inside the cells. So here this endolymph, as it is rich in potassium, it is similar to intracellular fluids. And here this endolymph is secreted by secretory cells of stria vascularis of the cochlea and by the dark cells. So just try to remember that they are secreted by the dark cells and secretory cells present in the striae vascularis. So this is all regarding the endolymph and perilymph. Perilymph is extracellular, endolymph is intracellular, perilymph is of sodium rich, or endolymph is of potassium rich. And now we are going to discuss regarding the few applied anatomy, that is pre-auricular sinus. So sinus, you all know, it is a blind tube with one opening. So here it is lined by the squamous epithelium, and it is formed as a result of incomplete fusion of tubercles between the first and the second arch. So you might have seen clinically also, and it is none other than the remnant of the first bronchial arch, and the opening is found in the front of ascending limb of calyx. You also know that if we are seeing the ear, and here it will be the calyx, and here will be a dot, which is a pre-auricular sinus. And here sinogram with radio-opaque dye, done to know, like we can use this sinogram investigation where a radio-opaque dye will be injected, so that with the help of that we can identify the extent of the tract. So try to remember, it is because of the incomplete fusion of the tubercles of first and second bronchial arch. Now regarding regarding the development of external auditory canal, we know that there are two parts. One is cartilaginous and another one is bony part. Here it develops from the end of first bronchial arch. So here in case of cartilaginous part, there are two fissures and infection from the mastoid. Already we had discussed regarding the foramen of Hershke, and in case of cartilaginous part, it is fissure of Santorini. Okay, in case of cartilaginous part, it is fissure of Santorini, and in case of bony part, it is foramen of Hershke. With just a revision, we already know that. And regarding the development of inner ear, this is also a little bit important, because membranous labyrinth, which is the inner part, developed from the ectoderm, and bony labyrinth developed from the mesenchyme. Okay, so embryology point of view, we can expect this MCQs. And now regarding physiology, organ of corti, which is the organ of hearing presenting inside the membranous labyrinth. And here we can expect three different types of cell. One is tunnel of corti. We are not going in detail, and this is more than enough in case of MCQ point of view, because in case of ENT we can expect very less question. So if we are having some basic idea itself, it will be more useful. So in case of organ of corti, which is the organ of hearing present inside the membranous labyrinth, there are tunnel of corti formed by the inner and the outer rods, and the fluid inside it is also called as corti lymph. And then comes the hair cells. There are two types of hair cells, that is inner hair cells and outer hair cells. And there are supporting cells called as Dater cell, pillar cell, Hensen cell, and Water cell. So just for an idea, I am just saying this, try to remember. And you should know something regarding the auditory pathway and how it works. So with the help of the mnemonic echolemma, you can easily remember E, eighth nerve, and C for dorsal or ventral cochlear nucleus, which is present in the pons area. Then comes O, that is superior olivatory nucleus, and then comes L, that is lateral lemniscus, and I comes inferior colliculus, and then it passes on to the medial geniculate body, and it passes on to the auditory cortex. So you should know the auditory pathway. So how hearing is happening? First it is hitting the E, that is 8th nerve. Then comes C, that is cochlea nuclei present in the pons, and then O, that is olivary nuclei, superior one, and then L for lateral lemniscus, and I for inferior colliculus, and M for medial geniculate body, and A for auditory cortex. So this is how you can easily remember the auditory pathway. So a few more one-liners for us. So first, most common malignant tumor of pinna is squamous cell carcinoma. If there is long-standing middle layer separation, it may predispose to squamous cell carcinoma. And the narrowest part of facial canal is 4 mm above the stylomastoid foramen, and a sound travels at 760 miles per hour or 1100 feet per second. And most common benign tumor, already malignant tumor we have discussed in pinna, and here the most common benign tumor of external canal is bony exostosis of external canal. So if maggots, that is insects in the ear, is called as myiasis. Don't confuse it with myiasis, which is related to the eye pupil. In vestibular neuronitis, the hearing will be normal. So these are all the MCQs. So here most common malignant tumor of pinna, SCC. If there is long-standing middle ear separation, that way predisposed to SCC. And the narrowest part of facial canal is 4 millimeter above the stylomastoid foramen, and sound travels 760 miles or 1100 feet second. Here it is hour. Don't confuse. And the benign tumor of external canal is bony exostosis of external canal, and maggots in ear is called myiasis, and vestibular neuronitis, the hearing will be preserved normal. Okay. Now, what is Cittali angle? This is none other than the sinodural angle. So it is none other than the angle between the plate of bone separating the sigmoid sinus from the mastoid cavity. So simple, sino is indicating some type of sinus. So sinodural angle is none other than sigmoid sinus from the mastoid cavity. It is a common site of residual or recurrent disease after surgery. Then comes oscillopia. So visual disturbance in which objects in the visual field appear to oscillate. So opia is related to the vision, and oscillo is related to oscillating. So now you can correlate. There is a visual disturbance. So if any object is appearing in the visual field, it may oscillate. Okay. So if there is complete absence of bony and membranous labyrinth, it occurs in a disorder called Mondini aplasia. Mondini aplasia. Then comes Frey syndrome, which is none other than gustatory sweating. Because of any type of trauma, the auriculotemporal nerve, like any type of trauma to the auriculotemporal nerve. So whenever we are eating, because of the misperception, there will be sweating. So okay, so that is called as gustatory sweating. Then father of neurotology, that is, he is Dr. William F. House. Okay. So then comes few more MCQs. First is Liar syndrome. It is none other than the splaying apart of internal and external carotid arteries of carotid body tumor seen on the carotid angiography. So you all know that this is how the external and internal carotid artery goes. So here in the bifurcation there is carotid body. So whenever there is tumor in the carotid body, then it may increase, the size may increase, and this two arteries, that is internal and external carotid arteries, grow, it will splay apart. Okay. And then comes that is called as Liar syndrome. And then visual viral infection causing the hearing losses, we can expect MMRH. Remember, MMRH, that is mumps, measles, rubella and herpes. Try to remember this mnemonic itself, that will be more helpful. In case of viral labyrinthitis, there will be sensory neural deafness, which may be severe and permanent. And the most common type of congenital articular chain anomaly is stapes ankylosis. Okay, so this is all, I think this is all regarding the ear infections, and we had discussed the anatomy, complete anatomy, applied anatomy. So in next class we will be discussing regarding the diseases related to the ear. So thank you so much, doctors. Try to revise before seeing the next video.